Good morning. I'm John Bitson, the Menard Family Director of the Sheila and Robert Challey Institute for Global Innovation and Growth. Welcome to the Human Progress and Flourishing Workshop. In this series, we bring in leading thinkers from across the country to discuss their insights from their research and their experiences, and to engage in a conversation with the NDSU community. Topics focus on big issues and potential solutions. And I'm super excited today about two things. One, we have a huge crowd here today, which is awesome, and that reflects on our speaker today. I'm super excited that Ray March, one of our own, is speaking today. He's an outstanding scholar for the Challey Institute, and I'm really excited for him to share his insights on FDA regulations and their unintended consequences. And so Dr. Ray March is a scholar in the Challey Institute for Global Innovation and Growth, and he's an assistant professor of agribusiness and applied economics. He teaches courses in microeconomics, the history of economic thought, and health economics. His research examines the public and private provision of government health care in the United States, and particularly in pharmaceutical markets. His research has appeared in the Southern Economic Journal, Public Choice, Research Policy, Journal of Institutional Economics, and other academic publications. He co-edited a book in 2022 called Pandemics and Liberty, and he is a research fellow at the Independent Institute and director of the FDAReview.org, an educational research and communications project on the U.S. Food and Drug Administration. He regularly blogs on health policy at the Beacon and the American Institute for Economic Research. And so again, super excited that Ray March is here today. There will be about 10 minutes for your questions at the end, so please get your questions ready. And without any further delay, let's welcome Dr. Ray March.
Make sure this works. Perfect. All right. Well, thank you, John. Audio good? Perfect. Okay. Thank you, John, for that very nice introduction. Thank you to all of you for spending your Friday morning with me talking about a subject I've been researching, gosh, for the better part of about 10 years. So my topic is going to be the Food and Drug Administration, its regulatory apparatus, what are the consequences of that apparatus, and tentatively, I stress this, right, can we do really anything about some of the problems that I'm going to highlight this morning? So very quickly, most of you are probably familiar with what the FDA does. At least broadly, the FDA is a regulatory agency, and what it primarily does, not exclusively, is find a way to bring to you safe and effective pharmaceuticals, medical devices, advertisement for certain kinds of medical goods. But that's a little bit misleading, right? The FDA primarily does that, but it also extends into a lot of other areas you're probably not familiar with. So by a lot of popular estimates, the FDA has some kind of a hand in regulating about 20% of all consumer goods in the US. And some of the more strange things I've found in my research the FDA helps regulate are tobacco, vaping flavors, not vaping, but flavors, how many pies need to be in a frozen cherry pie, not normal cherry pie, just frozen. Very specific about that. The size of holes in Swiss cheese, otherwise it can't call itself Swiss cheese in the United States. And then one of my personal favorite ones, insects. Sounds hard, it sounds kind of strange you would regulate insects, but specifically insects to remove skin tags. So what can a doctor legally prescribe to you with a horrible skin tag problem? What kind of leeches are allowed to remove those skin tags? So pharmaceutical regulation is one thing. The FDA involves itself in a whole host of things we might not think, one, exist, but two, would possibly need to be regulated. And I think that's at least one reason why the FDA is so intrinsically interesting and why it is worth so much effort to try to understand how does it decide fundamentally what goods and products are safe and effective. I want to focus primarily, not exclusively today, on pharmaceuticals because that is my primary research interest. And I want to briefly introduce to you how the FDA decides way before you get a prescription drug, what's safe and what is going to be useful or, if you will, effective enough to actually enter your body. So way before a pharmaceutical producer, if you will, applies for a new drug application, NDA, it spends about 6.5, 7 years of research independently, testing lab rats, testing, if you will, volunteers, trying to figure out if this drug does work, if it doesn't, is it safe for human consumption? And then once all of that happens, then the FDA tends to get involved. And typically the FDA is going to put a pharmaceutical through a three-step process. First, it wants to test for safety. Is it safe to use this drug? Takes about 2 years. Then it's going to test for efficacy. So does this drug actually do what we propose it's going to do? That takes a little bit longer. The sample size, if you will, gets a little bit bigger. And then finally in phase 3, if you will, the major clinical trial. That one takes the longest and incidentally costs the most. Then it's going to review, if you will, some forms of both. So can we say the drug is safe and does what it purports to do in a large sample size? When we get through all of that, the FDA spends 1.5 years being a bureaucracy and finalizing all of the data. And then after that, it actually gets to the market. Here's the kicker. A lot of people tend to forget this. After the FDA spends better part of a decade, sometimes 12, 15 years tends to be the average of going through that entire process, then it has what's called post-market surveillance, which is to say the FDA approved it, it's on the market, it still wants to monitor it carefully to make sure something didn't slip by in the last 15 years of research. Anybody want to guess how long the post-market period is? Indefinite. There is an average. A little more specific than indefinite. Yes. 5 years? A little higher. 10 years. A little higher. A little lower, goodness. 14 years. So the post-surveillance period is about as long as it takes the FDA to approve a drug. What does that tell you about the process? So that's 12 to 15 years, 3 very rigorous, defined, and somewhat difficult to follow procedures that get you to the approval process. Get this to work. That costs about $2 billion. Some of the estimates are closer to $3 billion. And that's every drug that gets to you. So just by comparison base, it's hard to imagine a $3 billion or a $2 billion project for a drug, and then 15 years of intense research, not including some of the preclinical trials. But just for reference, some of the longer periods of clinical trials to get a drug approved in Europe, so these would, if you would be some of the outlierishly long trial periods, those are about 3.5 years. And post-surveillance in Europe does exist, but it's a very, very short period. So it's very, very, very difficult, for lack of a better word, to get a drug onto the US market. It takes a lot of time and it's incredibly expensive. So one question I have as a health economist, and some of you might have as someone interested in the cost of healthcare in the United States or are concerned at all about getting safe and effective drugs, is why does it take so long and why is it so expensive? Given a lot of the same drugs exist in Europe, they do not take that long and they don't take anywhere near $2 billion to get to the market. So I think it's safe to start with a fairly interesting approach, an approach I've used, an approach Robert Higgs has used. I'll show you his quote in a second. I think it's fair to start with the question, rather, of who decides what's safe and effective enough to go into your body. It's the FDA, but specifically what in the FDA creates a process that takes 15 years and $2 billion to say yes, and then wants to watch it for 14 more years later just in case. And I think the answer boils down to incentives. A lot of things boil down to incentives. And what Higgs is going to highlight in that quote, I won't read it to you, is that fundamentally the FDA does not want to make a mistake, and thank goodness it doesn't. But in its incentive structure, the FDA has a very, very, very strong incentive to never make a type 2 error. Or to put in layman's terms, if you're not familiar with type 1 and type 2 errors, the FDA really, really does not want to be presented with a drug which has benefits and then some degree of side effects or costs, negative attributes to it. So the nasty part is that every drug has that. There's no completely safe drug. So given that realistic part of the problem, what does the FDA do to make sure it doesn't go through the process, get a drug onto market, and it turns out the drug is actually not as safe and effective as it promised, or as was thought? So one simple answer to that would be very conservative in actually letting any drug onto the market. About 1 in 5,000, if you will, chemical compounds make it to the FDA's initial process. Of that 1 in 5,000, about 1 in 20 are going to make it through the entire process. Another possible way to try to make sure you don't make that kind of error is to say you're going through the process, there's some ambiguity in some of these results, maybe we don't completely trust how the clinical trial was run, even though they're the ones who specify how it's run. We need more tests. You had the right sample size, you got the p-values, we're not entirely sure. Test it again. Go all the way to phase 3, have 5,000 people in this clinical trial, test it again. Takes a long time to get 5,000 participants in a clinical trial. It's also very expensive to get 5,000 participants through a clinical trial. So the FDA, at least from basic incentive standpoints, has a pretty strong incentive to be conservative in allowing things onto the market. It has a really, really big incentive to make sure it really clamps down on the approval process. And that, at least in part, explains why it takes so long and is so incredibly expensive to get drugs onto the US market. What I want to talk about specifically in this lecture are unintended consequences. It's not that difficult to imagine when the FDA wants you to retest and go through additional clinical trials that drugs get more expensive, or that it takes longer to get through the approval process, right? That's not an unintended consequence, that's kind of a logical consequence of this process. Interesting little tidbit, you can see up on the PowerPoint, even drugs that get through the entire process, not very many of them actually end up being blockbuster drugs. So drugs that hit the market and make their producer tons of money, enjoy the patent system going out 20 years in many cases, and if you will, line the coffers of what we might call big pharma. Very few drugs actually do that. Most drugs do not recoup the cost of going through the approval process. So it's not surprising then there are very few pharmaceuticals that make it through, and it's not that surprising that many pharmaceuticals are very difficult to obtain, even if they make it through. But what I want to talk about is the consequence of this incentive structure. I'm not the first to do this, but I've done some fairly involved research about recent outcomes about this incentive structure. So given there is at least presumption or reason, if you will, to believe that the FDA is going to be overly conservative or very conservative in its approval process, what happens when you have these drugs going through the process that ultimately do help people? That's wonderful, right? But they're still going through a 10-year process before anyone of any considerable sample size gets to use them and benefit from them. The logical consequence is that good drugs, safe and effective drugs by the FDA standard, can take a decade to reach you. What are the consequences of that? And if you go back in history, the FDA has had these powers since 1962. I want to give you some fairly recent examples about what this incentive structure can do to the US healthcare system and ultimately how it can affect patients. So Darcy Olson wrote a book several years ago called The Right to Try. It's about this FDA process and about how some of the perverse incentives it leads to. She estimates in this book that every single year, 20,000 patients with cancer die waiting for a drug that is then later approved. So that's not the case where you have a rare form of cancer, there is no treatment, and unfortunately you perish. Those situations are heartbreaking enough. These are patients where a drug is somewhere in the FDA approval process, is then later approved. It just so happened the patient couldn't receive treatment because the drug didn't advance far enough. That's 20,000 a year. About a more recent example. Let's go back to COVID. We'll talk about COVID a little bit more in a little bit. When Pfizer and Moderna's vaccine, the initial 2 COVID vaccines, went through Operation Warp Speed, which, if you will, was a regulatory structure agreed upon by half a dozen or so regulatory agencies, with subsidies going to several manufacturers. After those 2, if you will, initial vaccines go through this approval process, the FDA comes in and says, we need 1 additional subcommittee just to make sure. So rough ballpark, this is mid-November of 2020. What's curious about this case is that the process had already been decided and agreed upon. Operation Warp Speed was signed off on. We get to the end of the process, these drug manufacturers say, all right, we want an emergency use authorization, we've completed the process, the vaccines are 94%, 91% effective, let's go help people. What's the FDA's incentive? To be cautious. One more additional oversight committee. Oversight committee, in the process of forming it, in meeting, and ultimately coming to the conclusion that yes, we agree with what we previously said about Operation Warp Speed. These are the standards we're going to meet. That entire process takes 28 days. About 61,000 people died of COVID in those 28 days. There's a process, or if you will, a controversy going on right now about a very rare drug. Or if you will, a drug with a very rare ability to treat an unfortunately very rare disease called Friedreich's ataxia. How many of you have heard of Friedreich's ataxia? If you have, you probably have a relative who's affected by it. Fortunately, it's a very rare degenerative disease. But typically a victim of this disease or condition begins to suffer spinal stiffness somewhere around 14 or 15 years old. Because it's mainly manifests in the spinal system, you have severe nerve pain, you eventually lose motor function, you lose independence, and eventually, typically when you're in your mid-30s, the disease eventually takes you over. And as of today, there's no cure for this condition. There is one experimental treatment for this disease that, if you will, has some kind of ability to reverse these symptoms. Right now, if you have the condition, you have a shortened lifespan, you have a unfortunate and difficult life awaiting you. Every available treatment for it can, if you will, deal with symptoms, not treat the disease. But there is an experimental drug. Right now it's in phase 2 of the approval process, and it goes through phase 2, testing for efficacy. You want to meet the phase 2 requirements, you got to have 99% significance, right? Some of you may remember that from your statistics classes. What's the p-value at the end of this phase? 0.0014. Doesn't meet the threshold. So here's a difficult case, and these are cases that are brought before the FDA and brought before pharmaceutical manufacturers every day. If you fail phase 2, does the drug manufacturer withdraw? Do they try to rerun phase 2 if the FDA allows them? Do they try to find some kind of other avenue to get through another approval process? And this is a particularly difficult case and a difficult country going on as we speak. Because again, there are only 5,000 of these cases brought forth in the United States every year. If I want to pass phase 2 and get to phase 3, where I need to have a sample size of 3,000, I've got to essentially find an entirely new clinical group. And if I'm successful, if I get that p-value, I'm the manufacturer in this instance, I'm bringing a drug to market, trying to get a drug approved through a $2 billion expense to my own account, where there's about 5,000 people who get this disease every year. Do I withdraw? There are reasons to withdraw. What does that do for people with this condition? Here's one I've been following. Some of you may be familiar with the one. I've been following this for at least the last couple of years. That's an Owlet Smart Sock. It's a great little device. It was incredibly popular for a while in the United States, had a very big and loyal following in Australia, New Zealand, and the United Kingdom. The Owlet Smart Sock is essentially a little device. You put it on the foot of your infant, specifically for infants, so if you will, 6 months to about a year and a half. You can use it for younger children or newborns, but typically that's the age range. And it has a cool ability, right? As you can see, hopefully on the bottom of the picture, you can track your baby's heart rate and oxygen levels. There's no other commercially available product that could do both. You have products that can do one or the other. You don't have one that can do both. But quite literally, this little phrase, or if you will, little advertisement at the bottom of the Owlet Smart Sock 2, that was the most recent one, is what gets the Owlet in trouble. Owlet's been around for over a decade. FDA notices this is on the box. And they come forth and they say, is this a medical device? I mean, medical devices do track heart rates, right? Does that make the Owlet a medical device? And Owlet says, well, no, this is just a device. We haven't put it through a medical device testing system. There are, if you will, research papers in medical journals saying it's about 90% effective. FDA says you haven't gone through the test. And there's a process of about 3 or 4 months saying, well, what if we just remove the advertisement? So if parents want to use this to track, if you will, vital organ function for their infants, they can do that. But if we remove the advertisement, right, there shouldn't be a violation. They say, no, this is now considered a medical device. Put the Owlet up through testing. Owlet says we can't do that. So Owlet's removed from the market. Now, incidentally, if you go out to like a Walmart or any other major retailer, you can still buy an Owlet, but they no longer track these vital organ functions. It's essentially a nifty sock. This is 2001 when all this happens. Owlet is still not back on the US market, at least, and it can't help you track these functions. Does anyone remember it happens at the end of 2022? This little thing called RSV, right? Big wave sweeps the country. For y'all's age group, right, I'm talking broadly to the audience, I don't know who's out there on Zoom. But for y'all's age group, RSV is essentially a nasty virus, right? It can be nasty for several days. It can be a little bit nastier if you're an older demographic. RSV kills infants pretty regularly. And that's irregardless, if you will, of the state of your healthcare system. RSV is extremely dangerous, especially as it happens to be for young infants or newborns. So now we have a situation where the FDA was concerned about the actual truth of how effectively the Owlet Smart Sock could monitor heart rates and oxygen levels. Wave of RSV hits the United States. How are parents going to track these levels? There are other devices which monitor infant vital organ functions. Most of those, basically all of those, are in hospitals. So what the FDA did in this instance, in its preoccupation with safety and effectiveness, has taken away literally the only device on the US market that could help parents track these levels. Remains to be seen what's happened to RSV death rates. But here we have a serious problem. Hopefully by now you guys are seeing a pattern. It's not an easy pattern to swallow. A lot of what makes FDA research difficult is not data analysis, it's having a stomach to read about these things. What can be done? It's not easy. But here's what I've been trying to analyze, especially over the last couple of years. It seems, just from an economic cost-benefit analysis standpoint, if the FDA is overly, if you will, inefficiently concerned with safety and effectiveness, what happens if it reduces its regulatory standards? Probably the knee-jerk reaction to that, which a lot of people worry about, including myself, is, okay, so we sacrifice, if you will, the unintended consequence of being preoccupied with safety and having some of these problems like I presented on the market, but then wouldn't we end up with devices and goods that are not safe and possibly can't promise what they try to deliver on? So do we face that trade-off? Well, here's a difficult challenge, right? Even if we want to buy that hypothesis, which by the way I tend to do, how would we know that? The FDA literally says what the size of a hole in Swiss cheese needs to be. What examples do we have where it gave up regulatory authority? Up until several years ago, the FDA literally released press releases. Its commissioner, then Scott Gottlieb, came on and gave press releases to the public, and it was braggish and self-promoting that it had decided after decades it was no longer going to regulate the amount of cherries in frozen cherry pie. Great. That is deregulation, but that's a little bit of a small sample, if you will, or not quite as a convincing change in FDA policy to ask the bigger question: what happens when it gives up power? What do we actually see as a trade-off of safety and effectiveness versus goods reaching patients? So what I realized several years ago, really about 2021, is that the FDA did give up significant power in some avenues during the COVID-19 pandemic, which gives people like me, or people interested in how the FDA works, interested, if you will, in trying to reduce these unintended consequences, the ability to go forward and see, well, if it relinquishes power, what are the outcomes? And I want to begin with this question, analyzing it in context of COVID-19, with the somewhat, some of you may remember this incidentally, the somewhat problematic beginning of the pandemic, specifically with regards to COVID-19 testing. I'll explain what that picture up there is in a second. So during the early stages of the pandemic, the United States has very, 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 very little ability to test anyone. And the question is why? Well, when I dug through my research trying to figure out why it is there was such a testing shortage, it came up pretty quickly. The answer was regulation. Not just the FDA's regulation. There were a lot of regulations in healthcare, but the FDA certainly had a role to play in the testing shortage. So consider this, the first really couple of months, maybe month and a quarter of the pandemic, how many kinds of COVID-19 tests were there? For us, one. So there's one kind of test. So no testing variability in one person, one group, you'll find out who that was in a minute, has the ability to legally produce a COVID-19 test. Okay, well, once you have the test, you have to process it to get the diagnosis. How many laboratories are allowed to process COVID tests? There's a certification, 40. Across the entire United States, 40. Less than one per state. So given that incredible, if you will, lack of capacity, it's not that surprising, number I dug up in some of my research, that during the first couple of months of the pandemic, we had done roughly 1,200 tests. Interesting little story to go on with the testing shortage. That's Dr. Helen Chu. Dr. Helen Chu is an epidemiologist. She's also a professor of emergency medicine at the University of Washington. And Dr. Helen Chu in late 2019, in early 2020 is acutely aware there's a virus coming over the border from China, which has the potential to be a real problem. And so in her capacity as someone who runs a laboratory and as a infectious disease expert, she modifies tests she has for previous coronaviruses and modifies them in a way that they can test for COVID. Then she starts to take samples. Everyone remember where COVID-19 cases first sprung up? We tend to think of like New York being the major hotspot initially. It was actually Seattle, Tacoma. If you will, the first actual documented positive COVID-19 test was in Western Washington State. So right where Helen Chu is trying to initialize testing. And she does samples. She collects 30, 40 some odd samples. They test positive. She starts to document symptoms. And then she becomes acutely aware that these, if you will, the movement of this virus tends to suggest communal spread, or the thing you want to avoid in a pandemic. Side story, she also notices from testing one of her patients, that patient happened to have been very involved in communal living, specifically volunteering in a nursing home. Then we didn't quite understand how disproportionately COVID affected older populations or comparatively sicker populations, but there was initial evidence that that could have been a spot where it was spread. And she tries to do the honest thing, right? The ethical thing as an academic, but also as a concerned citizen. She reports the test to the FDA. COVID-19 is spreading here. And here's the evidence. What does the FDA do? Hopefully at this point we know enough about the FDA, we can kind of predict where it might lean. So in a correspondence with the Food and Drug Administration, she is told cease and desist. Stop testing. Now, why would the FDA do that? As she's told, I don't have the passage up here, these tests are not approved. You're using a test that's modified to to diagnose from another coronavirus. It's not for COVID. And what kind of laboratory are you using? Is it one of the 40 laboratories? Oh, no. Laboratory is not approved to run these tests. Cut it out. She tried. So, in dealing with these testing shortages, the FDA eventually, and by that I mean really around March, first week of March 8th, I think is the literal day the document comes out, it offers a new perspective. And it says we are going to deregulate. Initially, this is called the umbrella approach to testing. What it eventually comes to be called is, as you see in the title, test now, approve later. So in this document, it goes and it says, testing developers, if you think you can develop a COVID-19 test, go test. Come back to us with your data and then show us it's effective. It also goes to laboratories. Laboratories, if you think you can develop a COVID-19 test, laboratory developed testing is what these are specifically called. By all means, make them. Come back and prove it worked later. And then in another interesting turn of events, goes to the states and it says, states, you're no longer going to go through us, the CDC and the Center for Medicaid Services, to decide what is a certified laboratory test. That entire process, if you will, to get certified takes about 6 months. They say you decide which laboratories you want to test for COVID. So that's quite a difference, if you will, from cease and desist, stop testing. And it really is, as far as I've been studying the FDA, an unprecedented amount of deregulation. All right, putting our faith in someone else besides the FDA, what happens? Well, obviously we all lived through it. Testing capacity increases significantly. In some cases, we were testing hundreds of thousands of, or if you will, putting forward hundreds of thousands of tests and diagnoses per week, really by April. Less than a month after the FDA said, y'all handle it. For some reason, we cannot. Compare that to 1,200 over the first 2 months. Testing capacity shoots up. Various laboratories develop, if you will, saliva-based testing, so you're no longer limited to the nasal swab. And that was a huge controversy at the time. Lots of medical professionals said, there's no way you're going to develop a saliva test that's going to be as effective as the nasal swab. Actually, it was more effective. Market innovation. But that part's not the surprising part, really, because the initial question isn't, can someone make a COVID-19 test, right? Helen Shu did that, fidgeting with previous tests. The question is, if we allow for that kind of deregulation, what's the trade-off in terms of whether these tests are actually safe and effective? So the tests aren't dangerous. If they're not effective, if they give you misdiagnoses, they can be dangerous. But I went back and I looked. As of August 2020, there were about 140 different kinds of COVID tests. Some produced by major producers, major medical device producers, others produced by small laboratories. There are 140 of those. They all received what's called emergency use authorization. That's the FDA stamp that says, go forward, test for COVID, then provide us the evidence you're not providing a bad test. So 8 months into the pandemic, how many of those tests lost emergency use authorization? Evidence came back, not an effective test. 2. And I think even that's a little bit misleading, because one of those was by a private producer, which came to the FDA, said, the evidence is that this saliva-based test, one of the initial saliva-based tests, is not as effective as it could be. We want to withdraw it. So if you will, telling on itself. The other one was made by the CDC. If any of you had the unfortunate or the misfortune of being tested in North Dakota during the early months of the pandemic, those are the tests you had. Those are the tests we might remember had not only proclivities to give you false positives, but were also contaminated. Now, who's supposed to regulate against that? No surprises there. I think a reasonable critic of my assessment of testing as evidence that deregulation would help the process move in the right direction is that maybe I'm cheating a little bit. And it's a legit criticism. And the criticism for using that approach goes something like this. Yes, testing capacity increased. The tests were overall very effective, even without FDA regulation, or nearly as much regulation as it would previously have, but we're talking about tests. Right? Tests for coronaviruses existed. This isn't a major medical breakthrough. These are modifications of old tests. Other countries had developed COVID-19 tests. So maybe you're cherry picking. This was not that big of an advancement. Okay. What might be a more, if you will, interesting and I think telling example might be treatment. Because COVID-19 is still a novel virus, right? So if someone develops an effective treatment for COVID in light of lack of FDA regulation and administers the treatment effectively, that would probably be more convincing than 140 different people made tests. And for that, I want to talk about remdesivir. Remdesivir has an awkward history. The drug that multiple people gave up on is usually referred to as its nickname, at least before it becomes the standard of care, as others have called it for COVID-19. So remdesivir begins in 2015, and it's being used as if, at that time, of course, an experimental treatment to deal with really difficult illnesses that tend to spread quickly. So initially, it's being used as an experimental treatment to deal with Ebola. Sends its results to the Food and Drug Administration. Food and Drug Administration says, not effective enough. Haven't proven it's going to work. Kind of like that treatment for Friedreich's Alexia, right? Doesn't meet the standard. Sound familiar? Well, all right, Gilead is its producer. Gilead decides maybe we need to give up. Medical researchers back in the United States, specifically at Vanderbilt and UNC Charlotte and a few other large universities, say, no, don't give up. Let's wait again and try this again. Comes back at it. Starts to get used to treating MERS and SARS. Similar kinds of diseases. And there it's actually shown to be clinically effective. It can help people with these terrible illnesses. Sends the results to the FDA. FDA says, small sample size. Now that's not necessarily remdesivir and the people trying to administer its fault, right? Because there are only so many cases of SARS and MERS in the United States you can test on. The FDA says again, right, not enough evidence. Cannot advance in the process. This is going on, by the way, I love to read this quote to people. While clinical researchers are putting forward literature reviews on the effectiveness of the drug, this is in 2016, where they conclude evidence to support new indications for this compound against human viruses of significant public health concern. So needless to say, their assessment was quite different. But nonetheless, when COVID-19, the pandemic initially begins in China, then eventually reaches the United States, Gilead has no route forward. Gilead was literally giving away remdesivir in hopes of entering a clinical trial somewhere. What happens? At least in the United States, a lot of people believe the academic literature over the FDA. Doctors say, I think this could help my patient. I've got patients on ventilators. I've got patients with pneumonia. If you will, those were the critical stages of COVID-19. That's when all else had failed. The case was severe enough. Nothing else was helping. I think if we give this patient remdesivir, it'll help. And thousands of doctors protested the FDA saying, give us access to remdesivir. And the FDA at that time, somewhat stingy with emergency use authorizations, says, fine, but only through expanded access. This little known program where the FDA says, individually, you come to me, the patient, with your doctor's approval and medical records, we will review it. And if we decide it is worthy, then you can try to save your life. Excuse me, you can try this experimental treatment. So that works somewhat, right? So roughly in the first couple of months in the pandemic, again, 22 patients in the United States get accepted. They're allowed to use remdesivir. It's not just Americans, though. Other countries think remdesivir can help patients with COVID, too. Actually, about 70 other countries gained access to remdesivir over this period. There were several thousand people in clinical trials in China over this period that got access to remdesivir. And that's actually pretty remarkable because Gilead's located in the United States. How in the world did they get those drugs to China? Something about supply and demand. Eventually, the results start to come in. The 22 patients who were initially treated with remdesivir beat pneumonia, get off the ventilator, and recover. Early in the pandemic, we didn't think that was possible. So then literally about 5 hours down the road in Nebraska, a large independent clinical trial forms. Gilead sends a major shipment over. Patients in these Nebraska hospitals with the severest cases of COVID in that area start taking remdesivir, and a lot of them recover. So at that point, the FDA has some explaining to do. Early May, FDA says, emergency use authorization, we will give you remdesivir, we will spread it out. At that point, the CCS decides we're going to buy up all of the remdesivir and spread it throughout the country. Just needed the FDA to stand out of the way in this instance. So 500,000 doses spread across the nation. People start to use remdesivir and largely recover. Not entirely, it's a drug, it has side effects, certainly, some of which are pretty nasty, but by and large, remdesivir is shown clinically effective, as it was 5-6 years ago. And eventually, what I find most remarkable about the story of remdesivir is that by November 2020, you can do the math, right? May to November, the FDA says remdesivir is approved. Not granted emergency use authorization, approved. Full FDA approval to treat COVID-19. Think back to that graph I showed you about the regulatory process, right? That is not enough time to complete the FDA's approval process, not for a drug like remdesivir. But nonetheless, the FDA says full approval. That's a remarkable story from failing, if you will, in the approval process early twice for two different, I don't want to call them pandemics, right, but severe outbreaks, Ebola, MERS, SARS, 3, excuse me, to receiving full FDA approval. So quite literally, at the end of all this, not even the Food and Drug Administration thought there should be more testing. A few more minutes, I'll wrap up and we'll take some questions from the audience. What have we learned from all of this? I think initially, right, and this is the not so surprising part, when the FDA has an incentive to be conservative and require more testing and withhold drugs from markets, if there is a slight risk that it comes back the drug is not effective, that jacks up the price, that elongates the process to approval. That makes it difficult for drugs to reach market. The sneaky unintended consequence of this is that a lot of drugs are effective. Not all, certainly, but a lot of them are. And when those drugs get withheld from markets, patients suffer, in some cases with their lives. The tricky part about this is realizing those are unintended consequences of this process. Can we put our faith, if you will, in deregulation and less oversight? And I don't have a world of evidence, right? Because the FDA tends not to decrease its regulatory scope, right? The FDA has grown significantly. But in these few examples we find where the FDA relinquishes power and, if you will, entrusts more of a market process to define and develop goods which are both safe and effective, there wasn't that much sacrifice to safety and efficacy. So where does that leave us now? COVID, for the most part, is over. These case studies have been all wrapped up. The tests have been fully approved. They're not used as much anymore, obviously. Remdesivir is still, right now, it's the third treatment fully approved for COVID. It was the first. But what does this tell us about the possibility or potential for less oversight in the future? Because emergency use authorizations are interesting in that there's such a severe form of deregulation. There are other processes. There are right to try laws, which says the FDA doesn't need to be involved in this process. There are expanded access programs. Those are a little bit tricky because they're individual based, but they exist. There's also accelerated pathway programs where the FDA says, in some cases, right, pay an additional fee and we'll move you through the regulatory process faster. Other drugs get what are called priority review, where the FDA says there's a lot of promise to this drug, we'll move you through quicker. And I think all of these are interesting. But all of these face the fundamental problem I've tried to introduce this morning. Do you trade off safety and efficacy as dictated by the FDA for more access? And what I've concluded in my research, and hopefully have at least interested you in, is the idea maybe there's not that much of a trade-off. And with that, that's the time I have. I'll take questions. Yeah.
So I'm curious, as kind of the margin of what you're talking about, but it was all very much interlocking, especially during COVID-19. The role that regulatory agencies and the whole edifice of regulation, so I'm talking about state medical boards as well, in promoting uniformity of thought inside of the discourse, how does that feed back on the sorts of problems?
That's a pretty difficult problem. The problem, if you're listening online, the question is, there is a feedback loop, paraphrasing loosely what the audience member has said, right, where there can be a push for uniformity of thought, especially against questioning regulatory agencies, not just the FDA, but other agencies that have been involved in addressing the COVID-19 pandemic. Fair assessment? Loosely, no one get all of it. Uniformity of thought. It's a difficult problem. There is uniformity of thought, especially around the Food and Drug Administration, that it does provide an effective means of safety and efficacy. The fundamental problem with that is fear, right? Fear is the most difficult human emotion to ignore. So when fear becomes a primary motive, the, if you will, psychological, or tends to be the psychological response is, how do we get rid of the fear? And even when promises of getting rid of fear are extravagant and possibly misguided, right, people gravitate toward that. And the only real answer I can see to that, now that we've seen how much fear played a role in guiding people's actions during COVID, is that ultimately, if you're worried about getting sick and you believe there is a means to help diagnose you and treat you, if it happened to come from an antagonistic source, or if you will, a dissenting opinion, I think ultimately the fear of dying in COVID will be more reflected to that, so long as we understand this is what actually had happened. Now, that's a huge push forward, right? But I think ultimately that's how you address something like that. Yeah.
So going off with that question, and how much of that challenge is due to institutional rigidity? So if we look at the FAA a few years back, there was an issue with the Boeing 737 MAX. And so Boeing and the FAA selected to ground all those planes. But when they looked into the investigated, they realized that the Boeing engineers knew more than the FAA individuals who were responsible for the approval. And so how much of that is the situation here with the FDA? In terms of that, do the managers or the people at the top of the drug companies, how much do they overlap with the people at the top of the FDA and vice versa? Because that's what usually happens. So you work in a company 20 years, and then they kind of switch sides.
Yeah. So another good question, if you're listening on Zoom, the question's about institutional rigidity. To what extent, one of the questions, or part of that question, has to do with what is the involvement between the private sector drug producers and the Food and Drug Administration, what's sometimes called the revolving door, if you're not familiar with the term. And then the other broader question, I guess, revolving around that is, to what extent does the rigidity not allow for deregulation, right? Two different questions. I'll tackle the second one first. I think that's probably the bigger issue revolved around here. So for those of you not familiar, the revolving door is the idea that people employed by the Food and Drug Administration, managers, testers, like people involved in the process of saying approved or not approved, tend to get hired away or retire and then serve as advisory members for large pharmaceutical companies. The way you deal with that, unfortunately, is kind of me proposing my solution, which I'm not exactly sure how to get at, but if the FDA has initially less regulatory power, there's not that much of an interest in collecting up its regulators as advisory members of a private sector firm. So for example, in 1962, when you have the big FDA amendments, that's the amendments that come forward and saying the drug not only has to be safe, you have to prove that it works, what's called efficacy. Going from 1958 to 1968, the percentage of people hired away from the Food and Drug Administration, going to large pharmaceutical companies goes from about 7% to about 78%. And the fact that that happened to me tells me it's not pharmaceutical, at least then, it's not pharmaceutical companies pushing the FDA in a certain direction. It's the FDA getting regulatory power, which creates rents, form of rent seeking. And then, if you will, it becomes profitable to hire these people away to try to manipulate the rents favorably. So the problem I'd say is fundamentally the FDA has a tremendous amount of power, and that's obviously going to be in the interest of a private sector to try to figure out how do I make a profitable good in light of the controls coming from not my consumers, but from this agency. Now, in terms of stringency, that's also a tough one. I guess to tell on myself a little bit, the reason that the institutional structure wasn't as rigid is because of COVID. Because the reality is the FDA as we think of it today had never gone through a pandemic, right? The FDA as we think of it today started in 62. The last pandemic was 58. So we had never seen before, how is the FDA going to approach a rapid need for medical goods in light of people suffering and dying in hospitals, given that its approach is not at all amenable to being quick and adaptive. My hope fundamentally, to go back to the previous answer I kind of gave, is if we can actually understand what happens when the FDA relinquishes power and you see, in a lot of cases, extremely clear and somewhat miraculous results from that process, is that we can kind of entrust, yeah, the FDA needs to deregulate somewhat. And there is some level of hope with pharmaceutical producers, if you will, spending more time trying to get through orphan drug passages, trying to get through expanded access programs, at least as compared to previous history, rather than saying, try to influence the FDA slightly more. Now, what's going to happen to the FDA now that COVID is essentially winding down? We don't know. Yeah.
So obviously, if there's like the way it is now, how it's just expensive testing, I feel like there's probably a reason and like evidence that shows that sometimes further testing is necessary to like have safety.
Sure.
But obviously, when it's like 20 plus years that people are dying of disease treatment. But on the flip side, like what was it, like 28 days or so that the vaccines and stuff got through, do you think there's like a happy medium where we can make sure that there's not like long-term side effects, because I know that sometimes happens, but also so that people get it, but it's somewhat safe? That makes sense.
Yeah, absolutely. So the question is about trade-offs fundamentally. So in the examples I provided, right, that's a tremendous swing towards deregulation, which means that testing, and quite literally in the example of testing as you brought up, right, it's go test people, then prove that it works. That's extremely the opposite of what the FDA tries to provide, right? So those are two extremes. The question is, okay, is there a happy medium? And I think the answer is yes, but I don't think fundamentally the FDA has any incentive to find the happy medium. And that's somewhat tricky, right? But if the incentives of the agency are to be overly conservative, you're going to miss that medium. You will end up in those unintended consequences I had talked about. Now, what exactly is the happy medium? I'm not sure. I think that depends on patient circumstances. That could depend on broader epidemiological circumstances. That could obviously shift in either which way. But I think there's very little evidence that a bureaucracy, one, could handle that information, and two, has an incentive to respond to it. So hopefully that helps that question somewhat. Yeah.
I'm from the Department of Public Health. I have a number of significant concerns about regulation. So I think a lot of the examples you gave were from the pandemic. Sure. And I think we could all agree that the FDA probably needs some kind of a different process when we're trying to build a plane while we're flying. That was a difficult challenge. But in our Center for Immunization Research and Education, where we do a lot of teaching about vaccines, for example, the number one question we get is, and the number one concern that we get that is caused this explosion of vaccine hesitancy, is that the vaccines were rushed, we don't really know that they're safe, Operation Warp Speed, how warp speed was this? And we now literally have a crisis in trust in public health. And that perverse downstream effect, I think, of proposal for increased deregulation will cost, it is costing in many other ways. We now have falling off vaccine rates for all childhood vaccines because of that lack of trust in the safety process. Deregulation is going to make that worse.
Okay, so the question again for those of you listening online is, what happens when we start to deregulate? That undermines trust in public health institutions specifically. What is going to be the longer term effect of all of those? And as The audience member specifically said with regards to vaccine is there will be more vaccine hesitancy, not just for Moderna's vaccine or Pfizer's, but just broader, even childhood level vaccinations. It's a good question. It's an interesting question in regards to how much distrust should there be. I'd say to some degree, some of the distrust is healthy. We can't trust the FDA under normal circumstances. Again, I'm talking about the pandemic, under normal circumstances to provide goods in a safe and effective manner, given the expediency in which they're needed. So to that degree, that distrust might be healthy. Regarding broader trust in public institutions is not a cap-all that's dictated by the FDA. Some of the work you do that you mentioned, right, is not necessarily dictated by the FDA. It's educating the public in regards to scientific valid studies, in regards to previous decades of research and things like that. To the degree that you need the Food and Drug Administration to dictate public trust, I think that's going to be fundamentally a problem. I don't think the FDA, at least as it's currently devised, can be trusted with a lot of these difficult circumstances.
I would agree it's broader than just the FDA, but the FDA is hugely important in that they are the regulatory body that oversees vaccine safety and efficacy. And to me, the answer to try and get more trust in them isn't taking away their power and having them do less. And there's a reason for that, because lots of things get up. We talked about the COVID tests. I reviewed tons of them for the state health department. We're trying to get our hands on all of them. A lot of them were garbage. They have all kinds of false positive and false negative rates. There's a problem when you rush through those things, take regulatory things away and put out something. So your question to Dr. About why would the FDA say to Dr. Xu cease and desist? Because her test might be garbage. If she's putting out a test that's got a whole bunch of false positives and false negatives, that creates other problems in and of itself. I don't think the answer is taking away regulatory. It's to make it more transparent, to make it more rigorous, to have it very well defined, to have it consistent, and probably a separate parallel process for a pandemic for the acute problem we've had there. I can see that we need changes to that.
Right. So again, for the online listeners, right, what is brought up is that deregulation might be a little bit too strong, right? You can amend some of these processes where there's more transparency in theory will bring up more, if you will, increase public trust. That all might be true, but I still stand by my original assertion. The FDA was not ready for that. If the FDA wasn't ready for that, I think there is a reason to not trust them. If there is a different process for pandemics, that's just another way of saying the FDA wasn't ready. Sorry, like 8 different hands are up. I don't know who went first. I'll go with the gentleman in the back.
Yeah, it's not a question, but a comment.
Sure.
It deals with safety, efficacy, and risk assessment and culture. As you probably can imagine, military parachuting is inherently dangerous. And we accept a certain amount of risk. How much risk? Well, we have a policy statement from the commanding general of 17th Airborne Corps, which states, unless there's 3% casualties, it's not effective training. In other words, we still got to go out the door, but we have to accept a certain amount of risk. And that risk is related to how much wind do we accept. We could make it safer, but he doesn't want to because he wants every individual parachutist to have his head out of his butt and being part of the solution. And that's what makes it stay under that 3%. And so I think it's a cultural issue as much as anything else. That's why it might make a good case study for people to investigate.
Absolutely, I appreciate the comment. Let's see who else. Yeah.
So I assume that maybe the process of FDA is more maybe too accustomed to the type of drug, right? So it depends on how popular the drug is, how many patients are conscious to it. When they have multiple tiers, maybe categories of the process. So maybe it should be more flexible. So for each category, it's less patient, maybe more urgent. Maybe the process will be different. So if they define the process very clearly from the beginning, so it's more flexible and maybe more effective at the end.
Yeah, absolutely. A trade-off of the circumstances could dictate what the safety and efficacy standards. Well, that's what the gentleman behind you brought up, essentially. If there are 2 different processes given the external environment, that might be more effective in addressing a pandemic. The question, at least I find interesting in my research, is do you need that degree of deregulation? And if it works relatively effectively, then is that grounds to question the initial level of regulation? having two different standards, right, that's essentially what happened, right? It just so happens the different standard wasn't as dictated by the FDA as some of us might like. But fundamentally, again, right, if assuming my results are right, and again, I have two case studies, I don't have a lot of clinical data here. If you could drop off that much into deregulation and find relatively, yeah, this seemed to work, I think it's initial grounds to question the initial process, not just one brought up in terms of a pandemic or other emergency.
Okay, well, we're out of time. I think we can have this has been a great discussion, and I think you can see why I'm so excited about Dr. March's work. So let's give one more round of applause.